Welcome to MD Insights. I'm Matt Walsh of the Digestive Disease and Surgery Institute. Today we're fortunate to have Prashanthi Thota here with us today. And Dr. Thota is head of our swallowing center, and she's a gastroenterologist, and we're going to talk about Barrett's esophagus. But let's first talk about the swallowing center, Dr. Thota. What are the sorts of things that you treat in the swallowing center?
Thank you for having me today, Dr. Walsh. And I'm excited to be here today and to tell you about what we do in the swallowing center. So the swallowing center has been established more than 30 years ago, and it's a collaboration between gastroenterologists, surgeons, both foregut surgeons as well as thoracic surgeons, radiologists, and then pathologists. And we treat a variety of esophageal disorders, including achalasia, other esophageal motility disorders, Barrett's esophagus, eosinophilic esophagitis, and different functional esophageal disorders.
Great. And these are fairly common problems, you would say, that affects a great deal of patients?
Agree.
Okay. And let's talk about Barrett's esophagus. Where did that first come to be known?
So Barrett's esophagus was first described back in early 1950s by a surgeon by name Norman Barrett. So he noticed that there was gastric mucosa in the distal esophagus, and then thought it was initially a congenital condition. And over in the 60s and 70s, people realized that it is a consequence of long-term gastroesophageal reflux disease, and about 10 to 15% of patients with gastroesophageal reflux disease develop Barrett's esophagus. And then that is a precursor for esophageal adenocarcinoma. And the definition has changed over the past several decades. And now here we make a diagnosis of Barrett's based on the endoscopic findings, as well as the histological criteria of intestinal metaplasia too. And the main problem with Barrett's esophagus, it is very much underdiagnosed. Patients don't have any symptoms because of the Barrett's esophagus itself.
Okay, so that was going to be my next question. When should a patient think that they might have Barrett's esophagus?
So Barrett's esophagus is seen in patients with long-term gastroesophageal reflux disease. And then there are some risk factors for Barrett's esophagus. And then usually seen in men over 50, and then usually in white men. And then presence of hiatal hernias or visceral obesity, smoking, family history. These are all some risk factors for Barrett's esophagus. And in patients with acid reflux for more than 5 years with a combination of these risk factors, they should be screened for Barrett's esophagus.
Okay, so screening would include an endoscopy, is that correct?
The traditional method or the standard method right now is the endoscopy with biopsies, but I'm doing research on other non-endoscopic methods of screening, and actually we are doing an NIH-sponsored study now. It is to patients swallow a balloon capsule, the same way as we pass an NG tube or so, pass it into the esophagus in the office, inflate the balloon, and then collect the cells from the esophagus and then test them for intestinal metaplasia.
Okay. And if they were going to have an endoscopy, let's start there before this novel research, what is typically seen when endoscopy is done in someone who has Barrett's?
On an endoscopy, there is a salmon-colored mucosa in the distal esophagus, and then it has to be at least 1 centimeter or longer to make an endoscopic diagnosis of Barrett's. And then the biopsies will show intestinal metaplasia or these goblet cells within the epithelium, within the columnar epithelium.
So, as you said, it's typically associated with reflux disease, and patients commonly are on medication for symptoms of reflux. Will that prevent the development of Barrett's?
It would reduce the risk of Barrett's, but does it prevent it completely? The answer is no.
And does treatment change the risk of developing cancer from Barrett's?
There seems to be some recent randomized controlled trials showing that there is less neoplastic progression when we use these proton pump inhibitors like Prilosec, Protonix, Nexium, or so.
Okay. And with your research, how are you in the progress of those studies?
So we are doing a variety of research projects on Barrett's esophagus. One, as I have mentioned to you before, is this capsule balloon study to collect the cells from the distal esophagus. And then currently it is being done at multiple sites within US. And with the first generation device, it seems to be about 93% accurate in making a diagnosis of Barrett's when compared to the endoscopic findings. So far, about 90% of the patients are able to tolerate the procedure, and then we are getting enough specimen to make an accurate diagnosis.
And you're currently still enrolling patients in Cleveland for this study?
Still enrolling patients, yes.
Okay. Is there any thought in your mind when that might be available for general patient use?
It has actually been licensed. It is being marketed by Lucid Diagnostics, and it is available for general use. Is it going to replace the regular endoscopy at this point of time? We still have to wait and see.
Okay. And in terms of cancer risk, if you have Barrett's, your doctor tells you they do an endoscopy and you have Barrett's, what is the general risk that they might develop cancer in the Barrett's?
So the risk of cancer in Barrett's esophagus depends on if they have dysplasia. So dysplasia, as you know, are those precancerous changes within the Barrett. So usually there is a no dysplasia. Majority of the patients, over 95% of the patients with Barrett's esophagus have no dysplasia. And the recommendation for them, if there is no dysplasia, is to do a repeat endoscopy within 3 to 5 years. Then indefinite for dysplasia, that means there are these inflammatory changes and the pathologist is not sure if there is any underlying dysplasia or not. So in those patients, they're treated with aggressive acid suppression and then repeat the endoscopy again within 3 to 6 months. And in patients with confirmed low-grade dysplasia or high-grade dysplasia, the treatment is by doing this endoscopic eradication treatments, which include like endoscopic mucosal resection, radiofrequency ablation, or cryoablation.
So in someone who has no dysplasia but has Barrett's, what treatment do they need other than a repeat endoscopy?
So it is the treatment of their GERD, aggressive control of their gastroesophageal reflux disease, quit smoking, and if they're overweight, we recommend weight reduction, and then doing a surveillance endoscopy. There are certain patients with a family history of esophageal adenocarcinoma or Barrett's esophagus, or if there is a young onset Barrett's esophagus, a patient in their 30s, or with a long segment Barrett's esophagus, like 3 centimeters or longer, even if there is no dysplasia, we offer them ablative therapy because they have a higher lifetime risk of esophageal adenocarcinoma.
And are there genetic testing available for people who have a family history of esophageal cancer?
There seem to be at over 7 times increased risk compared to patients with no family history. And in terms of the genetic abnormalities, there is no single gene which has been identified to lead to, which increases the risk of Barrett's esophagus. In different studies done at our familial Barrett's esophagus study here, as well as at CASE, and then in the Seattle too, there are different types of genetic polymorphisms identified to be associated with Barrett's in these families, but there is not one consistent genetic abnormality identified.
So in people with high-grade dysplasia, that used to result in an esophagectomy in the past, removal of the esophagus. Is that no longer indicated?
We are almost never doing any patient, and that has been the way for the past 10 years or so. And ablative therapies are highly effective, and these are outpatient treatments, and patient gets to keep their esophagus. So very rarely, unless they progress to esophageal cancer or so, that they go for esophagectomy.
So if someone is being recommended that treatment, you would certainly recommend that they see someone like yourself. Is that correct?
Agree, yes.
Okay. And so tell us more about those ablative therapies. How many different types of ablation are available currently?
So the main one in over 90% of the patients we do is radiofrequency ablation. So radiofrequency ablation, there's an endoscopic catheter, and then which has a balloon, and the whole balloon surface provides the ablative treatment, the radiofrequency energy. So in patients with a 3 centimeter or longer segment of Barrett's esophagus, we pass this catheter through during the endoscopy and burn the tissue. Now, the other component of this is that the patient has to be on aggressive acid suppression therapy. Usually they are on PPIs 80 milligrams a day or so. And the reason is because if you burn the Barrett's tissue and then they continue to have GERD, then the Barrett's will come back again. And these are outpatient treatments. They're 2 months apart. On the average, patients need about 3 to 4 sessions or so for the Barrett's to go away completely, and afterwards they are in surveillance. In patients who are refractory to radiofrequency ablation therapy, then the options are cryotherapy, where the tissue is frozen with liquid nitrogen, or APC, which is argon plasma coagulation, or sometimes we do the EMR, the endoscopic mucosal resection, to remove the Barrett's tissue. And at times there are a combination of therapies used for eradication of Barrett's esophagus.
Okay. And what are the short-term complications a patient would expect from those treatments?
So with the radiofrequency ablation, for the first 2 days after the procedure or so, they have a really severe heartburn. And that is dealt with by using GI cocktail, Tylenol as needed, and Carafate. And it is a very safe procedure. There's a small risk of bleeding, especially if patients are on blood thinners. And there is about a 5% risk of strictures, and which are easily dealt with by doing a balloon dilation or so. There is a very, very small risk of progression. However, the risk of progression is much lower than when you compare to no intervention, and that we need to keep an eye on during the ablative therapies and also after post-ablation surveillance.
And is there any role for anti-reflux surgery to prevent the acid going up and helping? Would that help the Barrett's more than medication?
So there have been randomized controlled trials before, and then the consensus from this, from all the studies that we have is fundoplication superior to the medications on a head-to-head basis? The answer is no. But there are definitely patients who are partially responsive to PPIs and who have large hiatal hernias who may benefit from the surgery.
Okay.
Having said that, while going through the ablative therapy, sometimes we notice the reflux esophagitis. And in spite of being on the PPIs, those patients, I do send them for fundoplication, and afterwards they seem to respond better to the ablative therapies.
Great. What do you see on the horizon for either diagnosis or treatment of Barrett's, perhaps even involving some other work that you're doing currently? So
in terms of diagnosis of Barrett's, as I have mentioned, very few people are diagnosed with Barrett's esophagus. And up to 40% of the patients with Barrett's esophagus don't have any GERD symptoms. But screening everybody at risk for Barrett's esophagus is going to be cost prohibitive. And that is where coming up with this minimally invasive, non-invasive diagnostic testing for Barrett's esophagus come into picture. So these are like the balloon capsule test. And there is also actually a breath test developed in England, and it was tested in Mayo too. seemed to be a simple way of looking at the signature of the exhaled gases to make a diagnosis of Barrett's esophagus or so. However, they're not very sensitive, and that's where they have not become like a common place in the detection of Barrett's esophagus. In terms of the treatment of Barrett's esophagus or so, the current treatments require multiple procedures, and there definitely seems to be some degree of discomfort associated with the ablative therapies. So if there is a single procedure done at a single session and be done with it, then we can treat all patients with Barrett's esophagus with dysplasia or without dysplasia and eradicate the Barrett's.
That's great. Well, thank you very much, Dr. Thota. It's been very interesting, and we thank everybody for joining us on MD Insights today.
Thank you for having me, Matt.